So we're almost at the end. There's, I guess, slated for one more talk by me on future for heart failure, but this is less factual. It's more kind of, I guess, philosophical discussion, which we can go quickly. But essentially, I think the landscape of heart failure, even if 290 looks like this, will have heart failure as a problem. By 2030, greater than 8 million people will have heart failure. I think the things that will change, which are coming, is we'll end up respecting more of the paradigm for stages of heart failure so that we act early, try to prevent heart failure. There's more talk about it, otherwise we won't be able to sustain. Identifying risk factors and engaging patients and focusing on facts like 1 in 5 women at age 40 have a lifetime risk of heart failure, while they have 1 in 8 have a risk of breast cancer, but breast cancer is probably has much more awareness than heart failure. That's a discrepancy of talking about the need for engaging people's awareness. Next week is Heart Failure Awareness Week, very timely. So go back to your places, wherever you are, spread the word of heart failure, and there are a lot of resources that are available. The future also, and this, I just put it up because these are two editorials. I wrote an editorial, and I think Chris O'Connor wrote about the healthcare atmosphere of numbers and metrics and length of stays and readmissions and mortality indices are not going away. So as healthcare providers who are engaged in heart failure, we have a responsibility of balancing those metrics at the same time focusing on patients. So that's the future it's going to be. As long as we engage and modulate that, we will not lose focus on patients and then just end up treating numbers, because that's always a balance. And heart failure is truly evolving to become more and more as a multidisciplinary team with more integration of nursing, internal medicine, administration, because it's a challenge for everybody, not just a clinical problem. And things like remote monitoring, you guys have seen CardioMEMS. There are newer technologies, and I personally believe that the fifth vital sign is going to be intracardiac pressures. You'll talk about heart rate, blood pressure, temperature, respiratory rate, and then what's your PA pressure. I think that's probably going to be the future paradigm of measuring hemodynamic pressures. I have no idea who put it up there. No, actually, I put it up. It's also, and this is not, I'm not making it up, the toilet seat that automatically measures host of cardiac parameters. So telemedicine, technology, I think is creating or opening up a lot of avenues, at the same time some nuisance. I don't know what I would do for vitals that are transmitted from the toilet seat. And then, how many blocks can you walk, Mrs. Smith? And she says, what blocks? This is my circle tally. And this is true. There's one of my colleagues posted it on Twitter. He asked a patient saying, how much are you walking? And she pulled out her iPhone and then showed that she finished so many circles per day. So is this opportunity or is this too much data? And I don't know. And I think there is a lot of information overload, and we perceive this, but patients are not perceiving that. I got patients with iPhone calling my nurses every 10 minutes saying, oh, my heart rate is this much, my heart rate is that high. And the other day, one of the patients, after like a week of coming in and out of the clinic with the Apple phone, finally he threw it out. He said, I'm happy without it now. Can we handle it? Can any of us handle all this information? No, and I don't know, and that's a challenge in one way, but this whole organization of data that's coming in from many devices, iPhones, I think can be an opportunity which will evolve. I think Google's in the space of heart failure now. Apple's doing work with the big data, and I'm hoping and thinking that this will get organized to more utility than information overload. Engaging patients, it's becoming more and more paramount. This is our patient management conference where we actually invite patients with an intent of educating them, not just to learn, but take responsibility in their health. Why should I be responsible for your readmission if you go home and not take your pills and drink a bunch of water? But I am So I'll probably put you in a room and teach you why you shouldn't do that. And I always tell my fellows, non-compliance is a medical system failure. There are few patients who don't care about themselves and do what they want to do, but the majority want to help themselves. It's just that we do not have the time to give them the skills. So engagement of patients into conferences or whichever way you want to, and then we have ours coming in April 13. So if you have patients who have heart failure, to their caregivers, how to deal with it, I think this is becoming important and paramount across the country to share the burden of responsibility of caring for them. And I'm just highlighting a few aspects here and there. Nanotechnology is something which is emerging to be useful in medicine. I just put two examples. Eric Topol is known well for embarking on this nano sensors. And then Gerard Cote is somebody that I work with for an NSF grant. I advise on this grant. But it's just fascinating what they're doing, where they're going to be creating sensors, and that is an example of a sensor. If this works, it just goes on your skin to pick up things like BNP. Can we check a BNP from the skin to catch acute heart failure? Instead of putting in a sensor for remote monitoring, can we make it as simple as that? And the technology is not far out, because Topol had shown picking up troponin for acute MI. So this could be the future. Nanomedicine, where nanoparticles, and briefly nanoparticles are just nanoscopic, which are much smaller than microscopic, where they can navigate and go to areas in the body where you can reach it, where you can't reach with other. But this is actually our study from our lab, where we showed for the first time that nanoparticles are taken in. I don't think this is working up here, but you see these are nanoparticles. They're being engulfed by the cardiomyocyte, and they're able to go to the heart muscle and go inside. So the concept that we're embarking on, and other centers also, is can you load these with genes that can change your heart muscle and make it better than leaving it the way it is in heart failure. And that's, I think nanomedicine will be some of the future. Cardiac recovery has been a paradigm that will move forward much quicker than what I thought. Recovering a heart from where it is. And we don't think about it. Once you fail, you're treating it with medications. But these are examples of two conferences that have been focused on cardiac recovery. One is on chronic recovery in Utah. The other one is on acute recovery. But some of the landmarks that have happened that you need to know is just recently, the whole paradigm of how do you recover heart when somebody comes in with a heart attack was validated in this study by Naveen Kapoor, trying to change the concept that if somebody comes in with an acute MI, don't open the artery. Put in a pump, unload the LV, wait 30 minutes, twiddle your thumbs for 30 minutes, and then open the artery. And by doing that, in animals and in a feasibility study, they've shown that your reperfusion injury becomes much lesser so that you recover your heart better after a heart attack. So recovering a heart at the time of insult, I think is a concept that's moving forward. Just like Mawar said, don't worry about what's up here. But I put this up here because this is actually our lab's work on the first ever recovery model in heart failure, which means most of the animal models, they cause heart attack, and people have studied the mechanisms of what happens in a heart attack. But can we naturally heal a heart? And what we were able to see, and just to show the pattern here, you see how there's green, blue, and yellow, that's gene expression. From control to heart failure, it changes in one way, but we've shown that you can completely recover it back just by taking off the insult for the heart. So there is a natural recovery mechanism that the hearts can heal, and we see that in patients. Sometimes the hearts recover based on medications, but this is opening up avenues for essentially exploration of how can you recover a heart. Can you give an injection of a particular gene and then expect that to get better instead of just putting them on gazillion medications? So that's probably the future. Combined with cardiogenic shock and temporary support, and I think we've talked about the organization of shock teams, which is evolving. We have a shock phone, the numbers down there, and when we bear the call as a shock phone. But for cardiogenic shock, just like SIRS teams, we're organizing into teams where you can have an immediate multidisciplinary discussion, and this is more to come and get organized. In 2017, this publication kind of laid this in, and if you notice in the discussions we've talked, it's not about just putting a pump in and seeing what happens. You have to have discussions whether, can I truly get them to LVAD? Do you think that they'll recover? Can I decide here before doing any of these interventions, maybe they won't make it. So let's just not do anything. And I think this organization is getting more and more. There's a National Cardiogenic Shock Initiative where many hospitals have signed up. We're not a part of it. Where just like STEMI care, just like stroke care, this is becoming a national initiative where it'll evolve more and more. And long-term temporary support. It's kind of an oxymoron. What's long-term and temporary support? This is an example of, and Val Jeevanandam is a surgeon out in University of Chicago, but a new pulse is a pump which can be implanted through a surgical implant, and you have a small ECG kind of a monitor that goes under the skin that then uses that technology to pick up the electrical activity and time the balloon pump. So it's essentially a balloon pump with which you can go home with, and people are going home with this. So it's technically a temporary support, but it's not short-term that you're in the hospital, you're able to go home with it. There's another device called Aortic. This is actually still very early, but it's up here, developed at Texas Heart. Reynolds Delgado is one of the inventors, and that's the same thing. You put it in the aorta, it just hooks onto the aorta and then pumps blood. You could go home with it. I know many acute device companies are working on technologies where you can put in an Impella, for example, leave it in, and patients go home with it. So can you send people home with an acute support so that they could get better? Durable mechanical support, I think you saw Dr. Pagani talk about it. The technology is getting better and better and smaller, but a fully implantable, and for individuals who are not familiar with VADs, when we talk about fully implantable, when the LVAD is put in, you have a wire that comes out of the abdomen, and then the batteries or what are powering the source. And one of our biggest problems is that is a contact between the inside of the body and the outside of the body. And if we get rid of that, we'll relieve a bunch of infection problems. But how do you get rid of it? You need to put batteries inside your body and then cut off no connections outside and somehow charge the batteries. Right? How many of you have this Apple Watch? That's exactly what it is. You connect it, right? You put your charger on it, and it charges. So the technology exists. We were talking about it, but actually, again, Barry pointed this out. This was published just a few days ago. First ever implant. Barry, was done in what, Kazakhstan or somewhere? So it was done in Kazakhstan. It's a merger of Jarvik pump with a company called Levitrix or Leviticus. Their technology essentially is what we talked about. There are no wires, nothing coming out, and then everything is fully implantable, and you're charging it from outside, and with your charge, you can last about 8 hours. So this is, it's coming quick. In the next 4 or 5 years, I think the big companies who are here in the US will probably roll out this technology because we know it'll exist, and that'll definitely change the landscape of the replacing or recovering organs. And everybody saw this transport machine that Pagani showed, trying to see if we can get donor organs from farther and farther. I think that's hopefully the heart. There's a trial going on. Hopefully we'll get there. And then regrowing organs. If you notice this video, it's a heart where they're decellularizing the heart, and you'll notice it will become white because all the cells are being flushed out. And this is something, this decellularization technique was devised by a researcher called Doris Taylor. She's actually across the street at Texas Children. She was up in in Texas Heart. But by doing this, you are essentially getting rid of the cells, maintaining the skeletal structure of the heart, and then re-injecting cells to go back and grow. So the concept, which I think there are some trials going on in Europe, can you take somebody's heart, take it out, decellularize it, maintain this structure, put in stem cells and regrow so that you have an organ, and in the meantime, maybe you can use a total artificial heart to let them run around, and then you get a heart and put it back in. So the future in that regard actually is quite promising. Thank you, everybody. Have a good weekend.